Hello, friends. So, I'll be talking on this assessment of LV diastolic function and filling pressure as a part of ECHO series. So, I realized that I had not done this recording when I was doing the talk yesterday on heart failure with preserved ejection fraction. So, it's a brief overview, just as an extension of the talk that I've recorded on heart failure with preserved ejection fraction, where we did discuss about the whole concept of heart failure with preserved ejection fraction, where we need to ascertain that there is diastolic dysfunction. And increasingly, we are seeing in ICU that many of the patients come with heart failure symptoms with preserved ejection fraction, where we need to ascertain the diastolic function and the filling pressure. So maybe in next 10 minutes, I'll just take you through this overview. So, wish to acknowledge my colleague, Dr. Raghavendra Kotal, who helped me develop this content. So, yeah, so for diastolic function, what we need is a apical four-chamber view. So most of the intensivists who are listening to this would be very familiar now with using echo. So in four-chamber view, we put this cardiac probe in the fifth intercostal space in the mid-axillary line, or just below the nipple with the pointer facing down. So you get a four-chamber view. So the four-chamber view would look something like this. I'm sure most of you would already know this. So the heart with LA looks here and LV is here and RA and RV. And you would see a opaque structure here on the RV, which is called the moderator band or septomarginal trabecula. So this is a band which extends from the papillary muscles into the septum, which is called moderator band. So in the apical chamber view, you that is the fourth chamber. You don't see the aortic valve. So when you uh, just do a little sweeping action, you will see the aortic valve which opens up. So this is called five chamber view. So where you would see LA, LV with LVOT which is opened here, and you see RB and RA. So this is the apical five chamber. So when we are doing an apical, it is important to look at four chamber view, five chamber view, and three chamber and two chamber. The reason is when you're doing the four chamber view, the wall you see on the right side is the lateral wall. But when you turn anti-clockwise, you will get three chamber and two chamber view. So in the two chamber, we see the anterior wall here, which I will show you, and then we'll see the inferior wall. So when you do a three chamber, you would see anteroseptal and posterior wall, and this is important for all the trainees to recognize when you're doing apical view. So this is a five chamber view where obviously many of you would be doing left ventricular outflow tract velocity time integral to calculate stroke volume. So for that you need this five chamber because you would put the cursor with the sample at the LVOT and take the VTI measurement. And then you would do a PLR to see the VTI increase after you do a PLR to see the fluid responsiveness. So many of the intensivists would know that. So you need to do four chamber, five chamber, two chamber, and three chamber view. Two chamber and three chamber is important to see any regional wall motion abnormality that may be present in the anterior and inferior. So this is the two chamber. As you see, you have turned the probe little anti-clockwise. So you would get a two chamber, and in two chamber, the walls you see is the anterior wall and the inferior wall. So obviously you have to see whether there is some motion abnormality in these. So this is, uh, as you see, this is a typical two chamber view that you would see in the echocardiogram. So this is the anterior wall and this is the inferior wall that you would see to look at any regional wall motion. So then you would look at the three chamber view. So this is the three chamber view. So when you turn further anti-clockwise, so you would see RV which appears. So this is you see aortic valve, then LA and LV. So here the walls that you see is the anteroseptal and posterior wall. So that is why you would have seen cardiologists reporting as regional wall motion abnormality in the anterior wall or the inferior wall or the posterior. So you need two chamber to look at the anterior and the inferior. You need three chamber view to look at the anteroseptal and posterior view. So obviously when you do an apical, make sure you look for 2-chamber, 3-chamber, 4-chamber, and 5-chamber view for your stroke volume and LVOT VTI integral. So now we'll move into the Doppler measurement, which we are interested in for today's discussion. So this is just a schematic representation as to what really we look in Doppler measurement. So here you would look at mitral inflow. So there is a flow of blood from the LA to the LV. So here you would see the mitral inflow. And then you would look at the pulmonary veins which are draining into the left atrium. And this we call as pulmonary vein flow or pulmonary venous flow. So these two are very important to assess the diastolic function. So the physiology is because when there is diastolic dysfunction, if you recall the previous talk where I had made, so LV gets hypertrophied and you need increased LA pressure to empty the blood into the LV, which means there is a backflow into the pulmonary veins and leads to congestion and pulmonary edema. So that's why we look for the systolic and diastolic reversal in the pulmonary venous flow in diastolic function, so which I will talk about. Sorry, I think there is site which is getting stuck. Okay. So in the mitral inflow, we look for E by A and the deceleration time and the isovolumic relaxation time. So these are the three measurements we do. And here we look at the pulmonary venous inflow pattern, keeping the probe at the pulmonary veins. So, and when after we do that, we do something called E prime. E prime is where we keep the cursor with the sample at, with a tissue Doppler at the papillary muscle or the medial papillary muscle or the medial annulus of the mitral valve. We keep it at the medial annulus of the mitral valve and look for the Doppler to look at the exertion of this annulus, and we look at the velocity to make an assessment of filling pressure. So the filling pressure is measured by doing tissue Doppler at the medial mitral annulus, so that we get the E prime. So I'll just show you the steps. So here, the first step is any diastolic function, we put the probe with the sample at the mitral outflow. So when we do that, say, as you see, you have kept the probe with the sample at the mitral outflow. So then first step is to measure the E. So the first wave that comes is the E wave. So you would measure the E with by keeping the probe here. After this, you make a measurement of A. So here is the measurement of A velocity. So where the next waveform that you measure is the A velocity. So then most of the echo machines, when we do, it automatically captures, once you keep the probe on E and A, automatically E by A is calculated and given on the pin. I'll show you, there is a video which we have captured as to how we practically do this. It's a very, very simple. It will only take around 2 minutes to do this diastolic function assessment. So basically keep the probe or the cursor with a sample at the mitral outflow and press for the Doppler on the echo machine. So you will get a waveform like this. The first waveform is the E. So, and the second one is the A, and automatically the echo machine does the E by A ratio and puts up the figures. Then we look at the deceleration time. Not always we tend to do this in routine practice. So deceleration time is you measure from the beginning and the end of the E wave. The normal is 160 to 240 milliseconds. So 240 and above is normal. So 160 to 240, as it keeps coming down, there is diastolic dysfunction that is happening. So measurement of E by E prime is done using tissue Doppler. So where you keep the cursor with the sample placed at the medial annulus of the mitral valve, and then you put a Doppler there. So you would get a waveform like this. So once you measure at the first wave, so it gives you E by E prime. So how do we grade it? So once, as I said, you don't need to calculate E by E prime. As soon as you keep the cursor, it will, or the echo machine automatically captures the E prime and it does give you E by E prime ratio automatically is populated and it is given to you as a value, which I'll show you in the last video. So now you have captured E by A and you have captured E by E prime. So we need to understand how do we grade diastolic dysfunction. So clearly, as you would recall in the video that I've done heart failure with reserved ejection fraction, what happens in diastolic dysfunction is LV is hypertrophied, there is no easy emptying with the suction effect of blood from the LA to the LV, because LA has to increase in the pressure and blood is emptied into the left ventricle with a resistance. So the LA pressure tends to go up, and this LA pressure going up pushes the blood back into the pulmonary venous system, and congestion happens and pulmonary edema happens. So grade 1 is where E by A ratio is less than 1 and deceleration time is more than 240. The lesser the deceleration time, greater is the diastolic dysfunction. But grade 1, any one of us can have grade 1 diastolic because there's no grade 0. So grade 1 is normal basically. E by A is less than, but in grade 1, it is substratified as grade 1 and grade 1A. Then you need to check E by E prime to ensure that the filling pressure, this pressure is nothing but left atrial pressure, is less than 8. If it is more, then it means that LA is in a strain and the pressure has increased to empty the blood into the left ventricle. That is when we call as diastolic dysfunction. So grade 1A is where E by E prime is more than 15 millimeter mercury. That's the pressure. Grade 2, which by then you would characterize them as diastolic dysfunction. E by A is 1 to 2. It's very simple. Less than 1 is normal, 1 to 2 is grade 2, more than 2 is grade 3. That's all you need to remember. Deceleration time, if you're interested, you do put a probe and measure it from, measure the E wave from the beginning to the end. So deceleration time 160 to 240 is grade 2. And after grade 1A, the filling pressure is always tends to be a little higher. As you see, E by E prime will be more than 15. It's called as grade 2. Grade 3 is where E by A is more than 2, deceleration time is less than 160, or E by E prime is more than 15. So these are the simplistic way of how we ascertain. As I said, this is a very simple measurement and there is no huge learning curve. So any intensivist who can get a good apical view, just put the probe at the mitral outflow, put a pulse wave Doppler, you will get a E ratio. Just keep the cursor at the E wave and A wave, and the echo automatically does the E by A ratio and it gives it to you. After you do EA ratio, keep the cursor at the medial mitral annulus and plus a pulse Doppler. So you will get by E prime, which is automatically given the echo machine. So this is the waveforms. Normal, and you see the E is more than A. So very seldom in ICU when you're doing echo, you would see this pattern. In a normal, normally you would see grade 1. So you would see E which is less than A. But then once it goes to grade 2, grade 3, it looks like grade 0. So generally in a normal individual, just remember this, E will be less than A. And then pseudo normal is E becomes more than A, and E becomes very tall in grade 2 and grade 3 diastolic dysfunction. So this is something which possibly not many of you or many of us may not be doing. So it is good to understand conceptually the SD ratio of the pulmonary venous flow. So I'm sure, even I have to confess, I don't do this in a routine practice, but it's good to understand what to measure the pulmonary vein inflow. So again, schematically I've shown what happens once the LA pressure is increased and there is LV hypertrophy and diastolic dysfunction, there is a bit of a AR jet that happens. Okay, so there is a D wave, and then there is this there is a air flow which goes here. There is a backflow of blood into the pulmonary venous system that happens. So then you put a pulse wave Doppler, you get a systolic and diastolic, and then you measure the amplitude of air. So the LV filling pressure is when S by D ratio, systolic by diastolic ratio, is less than 40%, or the pulmonary venous flow AR amplitude is more than 25, or pulmonary venous flow AR time duration is more than 30 milliseconds. So, but what the simplistic way is, just put a probe at the pulmonary venous outflow and put a Doppler, you'll get the ST ratio. Look at ratio of S by D. If it's less than 40, you can remember it as increase in the filling pressure. So this is very simplistically what we understand in echo doing the diastolic functions. It's a very simple tool. Just show the video as to how we do it routinely in our ICU. Just pay attention carefully to this video. So as you see, we have put the Doppler at the mitral outflow, as you see. So we have put the Doppler, we have put the cursor there. You see, we have put the cursor there at the mitral outflow, and then we have put the pulse wave Doppler. So you get a waveform. As you see, oh, So as you say, as I said, most of the patients, as I said, the normal is E is more than A, but we seldom see it. Most of the patients we do in ICU, generally you'll see E less than A in a normal patient. So this is normal patient where E is A. But then once the diastolic dysfunction becomes severe, the E becomes taller and taller. Grade 3 it is much taller. Grade 4 it peaks up much higher. Okay. So after that, you see very carefully. Okay, so we are keeping the cursor there at the E. You saw that? See, we are keeping the cursor at E, then we are keeping the cursor at A, and echo automatically populates mitral valve E by A ratio, and it is given as 0.53. So less than 1 is normal, 1 to 2 is grade 2, and more than 2 is grade 3. So this is grade 1, as you can see, E by A. I would have called it, if it is normal, E should have been more. So, as I said, or any patient you do, it will be grade 1 diastolic function where E will be little less. So it is 0.533. So this is very easy. It only takes maybe 1 to 2 minutes to do this. After this, then we go on to do tissue Doppler to measure E prime. E, okay, I'll show you that. So you can see, okay, you can see here, this is the medial mitral annulus where you have kept the probe. And then there is a tissue Doppler TDI, sort of a knob that is present in the echo. You press the TDI, then the color of this whole thing changes. Once you press the TDI, then you have to press the pulse Doppler, you will get the waveform. Sorry. Yeah. Okay. Sorry. It's just gone back and let this whole thing play. Just replaying this video because the slide is jumping. So this is the E by A. I'll take you to the E prime. So this is the E prime, what you're doing. Okay, so you can see here, we just narrow the window a little bit. Sorry. Just leave the video. I won't try to pause it because it's jumping to the end slide. Oh, why this? Okay, see, this is the E prime window you get. So you just keep the cursor at the first wave that you see. So it's being kept at the first wave, and you get the E by E prime as you see. Sorry, I could freeze this. Sorry, it was jumping. So once you place the sample and the cursor at the medial mitral annulus, you put the pulse wave Doppler, you get a waveform like this. In the first waveform, as you see, I am keeping the cursor there. Once you press the cursor, you will get the echo machine automatically populates and you get the E by E prime without you having to do any manual. So here you see E by E prime is 10.2, which is obviously your left atrial pressure should not be more than 12. So it is pretty much normal. Less than 8 is normal, but more than 15 we don't want. So it is normal in this. So it's a very simple. It will only take 2 to 3 minutes. So in our practice, every patient in ICU, we expect our trainees to do diastolic function assessment, which only takes two to 3 minutes, and filling pressure to rule out diastolic. So the message is any intensivist who is dealing with a lot of fluid or a sick patient, please do a diastolic function assessment for all your patients and at least rule out that there is any diastolic dysfunction because the filling pressure is high, which means you have to restrict fluids and you have to address the diastolic dysfunction and mitigate the whole conundrum that will happen with fluid overload. So that's about this. So a very brief overview of diastolic function. You can do pulmonary venous, very simple. You keep the probe at the pulmonary venous outflow, press the Doppler. If S and D ratio is less than 40, then diastolic dysfunction is present. So, but we don't necessarily do this as a routine. But E by A and E by E prime is something that you can do as a screening for all the ICU patients. So thank you one and all. So you can visit my website www.drpradeepragappa.com to rehear to this. Thank you one and all.